you'd mentioned a drug called, I think it was Aresa,
Yes.
about breast cancer.
Mm-hmm.
I'm wondering if you could just, again, tell us about that, and if somebody would want to sign up for it or anything like that. Is that possible?
There are certainly trials going on. So Iressa, for which the generic name is gefitinib, is one of these new targeted therapies for cancer about which there is a great deal of excitement. So Iressa basically works by blocking the action of a particular kinase, which is an enzyme that is normally present in cells, but in cancer cells from some tumors gets overly activated by a mutation. And if you are somebody who has a cancer that has that specific mutation, Iressa can be extremely effective. I think I told the story of a woman whose cancer was diagnosed. She had lung cancer, which was already metastatic to her brain, in 2002 and expected to live for a few months. She's doing fine today, I'm happy to tell you, because this drug was the perfect antidote to her particular tumor mutation. Now, that's the good news. The troubling part of this is that Iressa doesn't work for about 85% of people with lung cancer because they don't have that mutation. They have some other way that their cells have gone haywire and are causing the cancer in their system. But it does say that we are reaching the point with Iressa, with the drug I talked about in my opening statement, which is another example of this sort of targeted therapy for cancer, where you can sample a tumor and say, okay, what's here? And then look at your list of drugs that are available and do the match. And as that match gets more and more possible, because the list of drugs and the list of targets gets longer, we're going to see a real transformation in the way that cancer is approached. And that's a great thing. But it's personalized therapy we're talking about now instead of giving everybody the same dose of chemotherapy.
Thank you. I'd like to ask you a question on gestational diabetes. According to the American Diabetes Association, gestational diabetes affects 2 to 5% of all pregnant women, and that's 135,000 cases every year in the United States. And it occurs, I'm told, in pregnant women who've never had diabetes before but develop it between the 24th and 28th weeks of pregnancy. And while it generally goes away after pregnancy, it can have health impacts for both the mother and the baby. Mm-hmm. I'm told that there's currently an insufficient system for monitoring cases of gestational diabetes to uncover trends and target at-risk populations. And for that reason, I and Dr. Burgess have introduced the Gestational Diabetes Act of 2010. And I'm wondering if you could discuss some of the research currently underway to address the need for comprehensive information on the causes and best treatment of gestational diabetes.
It's a very important problem and one that we need to address both in terms of research and in terms of just the public health and trying to identify individuals who have risks of this sort. Gestational diabetes is, in fact, a risk to the pregnancy as well. It is associated with higher birth weight, with prematurity, and certainly something that you want to try to control because the mother who has out of control gestational diabetes is also likely to end up with preeclampsia. But more than that, if you get the mother through this experience, and most do, the risks that woman will go on to full-blown diabetes are substantially increased. And ultimately, about half of women who have gestational diabetes will ultimately become diabetic. So it is apparently one of those circumstances where pregnancy is kind of a stress on the system, and somebody who may already be predisposed, it becomes more clear in the course of a pregnancy that that's the case. So we need both better methods to monitor during pregnancy, which means our medical care system needs to be, of course, accessible to those who need those services. It is not particularly difficult to assess this if that person's getting adequate prenatal care. And we need, of course, methods to prevent it in the first place. And it appears at the present time that the risk factors for gestational diabetes are pretty much the same as the risk factors for type 2 diabetes in general, which is to say family history, which is to say body mass index, obesity, and exercise. And what we've learned in terms of how to take people who are predisposed to diabetes and prevent that from things like the Diabetes Prevention Program are probably very applicable here as well. But certainly women who have gone through this experience and had gestational diabetes ought to have a particularly good opportunity to recognize the risks to their future health and to be given the same kinds of interventions that we now offer to people with pre-diabetes to try to reduce the risk of coming down with the disease. So there's a lot we can do there, but I agree that has not been fully realized.
I'd like to ask you about Charcot-Marie tooth disease. There is an innovative partnership between the NIH's National Chemical Genomics Center and the Charcot-Marie Tooth Association. I've worked with that association, and I think that this could serve as a model of future rare disease research and drug development. So I'm wondering if you could describe the program and offer your thoughts on it.
I appreciate the question because I do agree this is a very exciting program. My father-in-law has Charcot-Marie tooth disease, so this is a disorder that's not only something from my clinic but also from my family experience. And this is an interesting disorder which causes a weakness of the legs particularly, but also the hands over the course of time, and can be quite debilitating. But it is well understood now what the cause of that is. The genetic abnormality has been now laid out in great clarity. But what could you do about it? So working with the NIH Chemical Genomics Center, which is this remarkable facility that has been mentioned already at least once in this hearing, an effort is being made to identify a small molecule, which is sort of a drug, that would basically compensate for the genetic problem that's found in individuals with this type of Charcot-Marie tooth disease, so-called CMT1A. And that is an early stage effort, but it's a good example of this therapeutics for rare and neglected diseases effort that NIH is putting increasing effort into. Charcot-Marie tooth is too rare for companies to generally see this as a good investment for them in terms of developing a therapeutic. But with the Chemical Genomics Center working with academic investigators who know a lot about the disease, if they can push this forward to the point of identifying a promising compound, then you could imagine a company be getting pretty interested in licensing that out and carrying it all the way through to a clinical trial.